Hi everyone, my name is Emily Devereaux. I'm a member of the Adult Cystic Fibrosis Advisory Committee. On behalf of our entire committee, I would like to welcome you all to the third webinar series in our educational series on fertility and family planning for people with CF. Cystic Fibrosis Canada's Adult CF Advisory Committee provides perspective and advice on CF-related issues and advocates for public policies and programs to help people with cystic fibrosis. Members also foster and support an engaged and knowledgeable CF community. Among the committee's various initiatives, we are pleased to host this webinar series, through which different aspects of fertility and family planning will be discussed by a variety of expert guest speakers, as well as people living with CF that are willing to share their personal experiences. Please note this is an educational webinar series. CF Canada cannot provide any medical advice. Although the series will feature a few CF clinicians and other health professionals, we highly recommend that all persons with CF seek guidance from their CF clinical care team regarding their personal family planning process. Today we will hear from Dr. Beth Taylor, a health professional that is very knowledgeable in this field, as well as Kim Wood, a member of the Adult CF Advisory Committee, who will be sharing her patient experiences with surrogacy. We will then take questions after hearing from all of our speakers. All right. We are honored to be joined today by Dr. Beth Taylor to speak on our third topic of the series, fertility treatment options such as surrogacy egg donors and sperm donors. Dr. Taylor currently works as a fertility specialist at Paula Fertility in Vancouver, BC. She's an expert on fertility treatment options and has experience with CF patients. Dr. Taylor, over to you.
Produced in the testicle, they're stored in the epididymis, and then with ejaculation, the sperm leaves the epididymis, going out through the vas deferens, this big tube, and then some liquid is added at the seminal vesicles and prostate, and then ejaculation occurs. Now, 98% of men with cystic fibrosis have absence of the vas deferens from birth. So they're making sperm down here in the testicles, and it's being stored in the epididymis, but it's not able to be ejaculated because there's no tube. Now, women, it's a little bit of a different story. There's nothing that's absent in women, but there's a change in the genital tract. The cervical mucus tends to be thick, acting as a filter, precluding sperm after ejaculation from getting through the cervix. There's abnormal levels of inflammation and of mucus even in the uterus, which can prevent the sperm from traveling up towards the fallopian tube. And in some women in the fallopian tube, they'll have dysfunction of the cilia that line the fallopian tubes, which are involved in helping the eggs that come from the ovary get to the sperm. There was a question in the email that Kim had sent. Someone asked about whether it impacts ovarian reserve. We actually don't think CF has a major impact on ovarian reserve, but women can have a low ovarian reserve with any health status. So some people with CF will coincidentally have a low ovarian reserve, but it does not seem to be a major issue in women with CF. So ovarian function is generally preserved. The impact of CF is on the genital tract, meaning the tubes, the uterus, and the cervix. Sometimes there are a few case reports of women with CF being born without a uterus, but that's not common. So we can see that both sexes are impacted by fertility. And in this talk today, I'm speaking mostly about, heterosexual couples who are trying to conceive, but I'm happy to veer off into, non-gender conforming and same-sex couples if that's relevant to the audience. Patients with CF are very well versed in genetics, and so I'll just mention that, of course, CF, there's a gene mutation involved, and if a person with CF is wanting to have children with someone who does not have CF, because there's a high carrier rate, particularly in Caucasians, we usually encourage the partner to have CF testing to give them a real risk assessment for how likely it is that their children might have CF. Now, I admit that's controversial. I had a woman with CF just last week who was married to a Caucasian male. They declined CF testing And she said, if you did CF testing and screened out people with CF, I wouldn't be here. So I admit that that's controversial, but that is offered if people do want to know the status of their partner, really for risk stratification, knowing what the chances are. And for people that want to know their risk, and if their risk is deemed elevated, they can consider undergoing pre-implantation genetic testing, which you see here, PGD, and identify embryos that would give rise to a child with CF, and decide if they'd like to do anything with that information. Some people choose not to use those embryos, and some people are on the other end of the pendulum and choose not to even have any testing whatsoever. So that's a real personal decision, but we do offer that so that people go into reproduction kind of with their eyes wide open. I don't think there's any males on the call, but I'll just mention this. As I showed you in that diagram before, guys with CF, they still have sperm. They don't ejaculate. Most of them don't ejaculate any sperm, but they will have sperm. And so we just need to get it from them. And so let me go back up to that diagram here. So there is sperm in here, but we can't get it out. We can't build that tube. So what we do is we go into the epididymis or into the testicles and extract the sperm. So into the epididymis is called percutaneous epididymal sperm extraction or a testicular sperm extraction. And we get the sperm, and typically we get it when we freeze it, and then get ready for the female partner to do IVF. So that's how we both confirm that there's sperm there, but also get sperm that we can use. I want to mention that this sperm cannot be used to replicate sex or for what's called intrauterine insemination. Sperm that comes straight from the testicles or straight from the epididymis, that sperm actually needs help to fertilize an egg. So those people would need IVF, and I can come back to that in a minute. But this sperm is great sperm. The CF guys have lots of good, healthy sperm, but that sperm cannot be used for natural conception. It can only be used for IVF. All right, so I think we know what to do. If a guy has CF, we go in and get the sperm, we freeze it, and then we're able to use it in IVF. For women with CF, their options for conceiving, well, they could just simply try to conceive. We know that fertility rates in people with CF are still fairly high. They're about, depends where you look, they're about half of the fertility rate of the general population. Just going to make sure is everyone able to follow along? I just want to get feedback at this point. I'm about a third of the way in here. I just wanted to get some feedback. Is anyone having any issues hearing or seeing anything? Am I going too fast or too slow? Is all okay? All right. No feedback means good feedback. So females with cystic fibrosis, again, intercourse, they can simply time intercourse and get sex have sex the old-fashioned way and very likely to conceive. Those that don't, will often help them with insemination or in the extreme IVF. So let's take a minute and touch on each of these. I think this is the meat of our talk today. So having intercourse. We recommend, for sort of optimum chance of conceiving, we recommend that couples have intercourse every 2 days, starting typically around ovulation, which is usually the middle of the menstrual cycle. So we start around day 9 or 10 and have intercourse every second day. Usually from, say, day 10 to day 10 until day 14 or 16, something like that, like an odd number of days having intercourse. We discourage lubricants because remember we already have this concern about whether the sperm can get through that thick mucus. We don't want any more mucus or any viscous liquid in there that could slow that down even further. And to help people time intercourse even better, they can use urine ovulation predictor kits. So those are just, you buy them at Shoppers Drug Mart or any pharmacy, and the urine can be tested to predict when ovulation might occur. And that would be the day to have intercourse if you were trying this way. We follow that same principle. On the day of ovulation, we want sperm inside you. And if you can't do it with intercourse or it's not working with intercourse, we'll consider insemination. And what's involved in insemination is we take a sperm sample, and that sample is washed. The liquid is washed away, and we take just the concentrated sperm, and that sperm is put up what's called intrauterine insemination. Quite effective if your cervix is the issue, and sometimes only trying it do you know that. The benefits of that are that it's not particularly expensive compared to some of the other things we do. So IUI or intrauterine insemination costs right now $650, and it's done once in a menstrual cycle. Quite often we'll pair it with some fertility medication so that when you're ovulating, you'll see more than one egg coming down the tube, and so that would boost fertility even further. But so that's the treatment called insemination or intrauterine insemination. And then the other treatment is in vitro or IVF. What's involved there is a woman would take a series of injections, typically about 10 days of injections, so that their ovaries would grow many eggs. And then those eggs would be extracted. That extraction occurs through the vagina. And when the eggs are extracted, they're fertilized with the male sperm. And the embryos are created. And then the embryos are put back into the uterus. They can be tested before they're put back into the uterus. And that makes me circle back to what we talked about at the beginning. They can be tested for cystic fibrosis or other genetic disorders or whole chromosome disorders like Down syndrome, as an example. And so those embryos could be tested in advance of an embryo transfer to sort of try to optimize the health of any child that's being created. And so that's what's involved in IVF. And I'm going to dig a little deeper into IVF in a moment, but I wanted to go back to this slide about pregnancy risk. Because I think, we have the technology to get women with cystic fibrosis who are infertile. We have the technology to get them pregnant. And the question is, should we? And most often the answer to that is yes, but sometimes it's no. And we lean on your pulmonologists, your CF doctors to kind of guide us through that. And we wouldn't really engage in fertility treatment until you were really well versed on what the risks in pregnancy might be, and particularly with your disease status. So we know that there's a little increased risk of miscarriage in women with cystic fibrosis. There's a large increased risk in preterm birth. And most of those births because the mom gets sick, and so the birth has to be brought on in the interest of the mom's health. And typical health issues in pregnancy are, of course, pneumonia because there's decreased lung volume and diabetes. Maternal mortality is fairly high in cystic fibrosis at 1% compared to much less than 1 in 1,000 for people without cystic fibrosis. So it's quite a dramatic increase in mortality. So pregnancy in someone with cystic fibrosis is not considered lightly. And hence the movement now more and more from the CF clinics is to send us patients to discuss surrogacy. Now surrogacy, a prerequisite to surrogacy is you must have embryos. So I'm flipping around here quite a bit, but so you must do IVF in order to use a surrogate. Because, if you want to pass on your genetic material, meaning your eggs and your partner's sperm, the only way to pass that along is to do IVF, make an embryo, and then put it into a surrogate. As an aside, there is such a thing as traditional surrogacy where the woman who carries the baby is also the one who gives up her eggs. We don't do that at all of it. I don't think you'll find many programs in Canada that would do traditional surrogacy. So we're really talking about surrogacy where the woman carrying the pregnancy is not related to the baby she's carrying, which is gestational carrier surrogacy. Again, a prerequisite of that is IVF. You need embryos to put into that surrogate. When you do IVF, you're given that choice in advance of an embryo transfer of testing these embryos. So you can see here we start out with an egg. We fertilize it to make a zygote, and then that cell splits, makes 2 cells, 4 cells, and blah, blah, blah. The splitting continues out up for about 5 or 6 days until you get to what's called a blastocyst. And the blastocyst is this embryo that we're working with in IVF, and it looks quite a lot like this. This is a photo of a beautiful blastocyst here on the right, showing the baby, or the epiblast, and the outside is the placenta, the trophectoderm. And what we can do, and we're getting better and better at it now, is we can actually biopsy a few cells out here from the rim what's going to be the placenta. So we're not biopsying your baby. We're biopsying the placenta. And when that gets biopsied, then we can test it and figure out, does it have cystic fibrosis? Is it a carrier of cystic fibrosis? Does it have a big chromosome problem? Does it have some other genetic disorder? And we can identify and figure out which embryos are the healthiest, and then use those either into the woman who has cystic fibrosis if she wishes to carry and that's medically suitable, or to put that embryo into a surrogate. I want to just mention, just to clarify things, when you're reading about the IVF process, you will see PGT, PGD, PGS, and CCS. All these silly acronyms. We're trying to reconcile. All the clinics are getting together in North America and saying, let's just call it PGT and PGD. PGT is where we screen for whole chromosomes, Down syndrome, trisomy 13, trisomy 18, monosomy X. The big chromosome problems are screened for. PGD is when we're going in and trying to diagnose a specific gene mutation. And so many people, with or without CF, ask us to do PGT. That's a screening that has value for lots of people. PGD is relevant for people who have genetic mutations. So that's just to clarify that, because that comes up quite often. It's a bit confusing. All right, so let's focus in a little more on that. So you've got embryos. You've gone through the cost and expense of IVF. IVF costs around $10,000 and about $5,000 in medication. So it's not cheap. But you've gone through that process and you've gotten embryos. Now, where do we put them? Do we put them into you, or do we put them into the gestational carrier? And let's talk about the scenario of putting it into a gestational carrier here in Canada. So there's only two types of people in Canada: people that think surrogacy is illegal, and people that recognize that surrogacy is not illegal. So surrogacy is not illegal in Canada, and it never has been. What is illegal in Canada is brokering surrogacy and paying surrogates beyond reasonable expenses. So with that in mind, you can absolutely do surrogacy as long as you follow it in that framework. In 2018, there were nearly 800 babies born from a surrogate in Canada. And that's almost double what it was 5 years earlier. So surrogacy, year after year, there's more and more surrogate babies being born. As it sort of opened up and people realized there is a framework by which you can do surrogacy in Canada that is safe and legal and positive for all parties. So much so that Canada's kind of become this international hub for surrogacy, as other countries who don't have good laws and regulations are shutting surrogacy down. A great example, India is shutting surrogacy down, Thailand, Vietnam, a lot of these other, and it's illegal in China. And as a result, people are looking to countries to do surrogacy, and Canada and the U.S. have really reasonable surrogacy laws, in my opinion. So surrogacy is possible. A surrogate to carry your child could be someone you know, or it can be someone you identify through an agency. Most of the time, people are identifying surrogates through an agency. There's a real advantage to finding someone you know, mainly in cost. But it's often difficult to find someone to be your surrogate. And we can talk about strategies of how to find people or approach people, if you like. But really, surrogates are unknown or known. And an ideal surrogate, whether there's someone you know or someone through an agency, ideally they are less than 40 years of age, have a reasonable BMI of less than 35. They had to have had an uncomplicated term pregnancy and child for themselves, and afterwards they had the post-pregnancy had to be a healthy time period as well. So they had to have done a really successful pregnancy for themselves first. They don't have to be done having children of their own, but they do have to have at least one child of their own that they gave birth to. And the surrogacy agencies know this, so they would not really show you a profile of a surrogate if you engage with an agency that didn't really meet those basic criteria. And now what happens when you go through and you identify a surrogate, like I say, from an agency or from someone you know, you contact the clinic, and as a clinic, we screen her and make sure that she's medically suitable to be your surrogate. psychologically suitable to be your and psychologically suitable to be your surrogate. So we go through a screening process. These surrogates are typically not right here in Vancouver. They might be in northern Alberta, or we have a surrogate right now in Nova Scotia. It can be all across the country, and that the geography doesn't really limit us. It causes added expense, though, to bring a surrogate here to Vancouver, but really geography doesn't limit us. You can use a surrogate from anywhere. Most surrogates are coming from outside of Vancouver because it's so expensive here to live. So we bring the surrogate here. We talk to her, we screen her, the nurse screens her, I screen her, then we have a counselor that screens her, and we make sure she's a good candidate. And that process takes about a month to do. And once we kind of check that box off, then they go into legal, and then they get a legal contract with you, and that legal contract is reviewed by a second lawyer as well. So it's sort of you and the surrogate create a legal contract, and then the surrogate has a separate lawyer who reviews it with her interest in mind. So independent legal advice is obtained, and then we're ready. So that might take a month, and then the following month we're ready to put the embryo or embryos into the surrogate. I've put a list of the agencies. There's the big ones in Canada. There are others for sure. But these are ones where a lot of the surrogates in Canada are coming from. Canadian Surrogates Online, Canadian Surrogate Online, Canadian Fertility Consultants, and ANU. And there's others, as I say, and there seem to be more popping up. You might say, well, you just told us that it's against the law to broker surrogacy. What are these agencies doing? Well, what they're doing is they're not being paid for brokering surrogacy. They're introducing you to a surrogate, and then they're being paid for surrogacy support, because you can't be paid to broker a surrogate in Canada. So they don't technically charge you for the brokerage. They charge you for the management of the surrogate and helping her through the treatment process and early pregnancy. Now, there are other options besides using your eggs and your sperm. And the same fertility issues that can batter people with cystic fibrosis are the same fertility issues that can happen to other people. So some people with CF have poor eggs or low egg quality, or they've waited too long. They're in their late 30s or 40s or something by the time that they decide to have children. And in that situation, the egg supply or health may be limited, and in which case they can use donated eggs. Males who carry CF may opt to use donor sperm instead of undergoing a sperm extraction. Or if they have poor quality sperm, we extract it, they may opt to use donor sperm. That's readily available. And of course, adoption and child-free living are options. I have this slide, just you can have a copy of it. Just listing some prices down, and we can talk a little more in detail about prices, but I wanted you to have sort of a reference for rough costs of things. Now, I'm known to be a quick speaker. I hope this is okay, but I'll just give a summary then, that we know that CF can impact fertility. We know it can affect male and female. Pregnancy is higher risk. If a couple where one partner has cystic fibrosis is trying to conceive, we can help them with helping them time intercourse properly. We can help them with insemination, or in the extreme, we can help them with in vitro fertilization. And in vitro fertilization would also be used in the event that a couple is exploring surrogacy. So I'm going to leave it there, and I'll mute myself. If anyone wants to ask a question, then I'll unmute myself just so we can start a dialogue if there are questions, or perhaps Kim wants to begin with her kind of her side of things.
All right. Thank you, Dr. Taylor, for that great presentation. At this time, we're going to hear from Kim Wood about her patient experience before we move on to the question period. Kim lives on Vancouver Island with her husband, James, and their 2-year-old son, Charlie. Kim has a background in nursing, but is currently focusing solely on maintaining her health and raising their son. In 2016, after 5 years of trying to become parents, Kim and James decided to use a surrogate and were lucky enough to have a close friend offer to do so. In 2017, they welcomed their son to the world. Kim understands firsthand the struggles that come with fertility issues and is passionate about supporting others with CF through the process of becoming parents. All right, Kim, we'll leave it to you. All right, thank you. Can everyone hear me okay? I'm assuming, yeah? So our surrogacy journey began 4 years after my husband and I began trying to start a family. At that time, my health was pretty unpredictable and very up and down, so assessing whether or not it was safe for me to carry a pregnancy was done continuously, really. Throughout that time, I required IV antibiotics about every 4 to 6 months, and my PFTs fluctuated between the 50s and 60s. My weight was fairly stable, although it did take some effort to maintain. I had stopped working completely, which gave me more flexibility to focus solely on my health. At that time, I was seen by an obstetrician who had experience with CF pregnancies, and early on, he did feel that it was safe for me to carry a pregnancy. However, we were concerned with the fact that I didn't have long stretches of stability between exacerbations. So the likelihood of me experiencing an exacerbation during pregnancy was fairly high. I know exacerbations can be treated while pregnant, but it definitely adds a level of complexity. And for me, aside from having CF-related diabetes, and chronic sinusitis, I was also diagnosed with secondary adrenal insufficiency, so things were already fairly complex. And during times of stability, these were all very manageable. However, during exacerbations, my CF team were concerned about some of the limitations that pregnancy can cause when choosing a treatment plan. So it seemed sensible to explore other options to start a family. The decision to use a surrogate was not an easy one, especially because there were times when my health was perfectly fine to carry a pregnancy. And there were many factors that came into play when we were thinking about using a surrogate. Ultimately, however, the instability of my health is what dictated our decision. Once I began thinking beyond my own desires of being pregnant and started thinking about the health and safety of our future baby, the choice became very clear. At the end of the day, I wanted to be a mom, and for me, it was relatively easy to forego pregnancy if that meant a higher chance of stabilizing my own health before baby came and having a healthy baby. Using a surrogate meant I could focus solely on keeping myself as healthy as possible without any extra strain on my body, so I could be healthy and ready for when baby came. It also ensured that there were no limitations to potential treatments I may have required while expecting. Once we decided to have a family, we were lucky enough to have an incredible woman come forward and offer to be a surrogate for us. So once we made the decision, it was pretty easy to begin the process. I will say, though, that my husband and I both needed time to grieve the loss of starting a family in a typical way. There was definitely a huge sense of loss. Going through rounds and rounds of unsuccessful IUIs, inseminations, and IVF cycles was not easy. It was emotionally exhausting and left me with a huge sense of defeat. So it was important for both my husband and I to process that sense of loss before we could move forward. Luckily, though, we did have other options, and that wasn't the end of our journey to become parents. The way we started viewing our journey was important when coping with the whole process. Instead of seeing it as a loss, we saw it as an incredible privilege and were overwhelmed with gratitude. So after Dr. Taylor did the screening, she screened our surrogate, which included blood work and scope of the uterus and an assessment. We began the next steps, which were to meet with a fertility counselor and have a lawyer draw up a surrogacy contract. By this point, we had had many in-depth conversations with our surrogate about expectations, needs, and requests throughout the pregnancy, labor, and delivery from both sides. Cost coverage, appointment attendance, what our relationship would be after our baby arrived, which was all detailed within our surrogacy contract. Because our relationship with our surrogate was and still is very open, and we both have very sensible and pragmatic personalities, it was fairly easy to be open and honest about our requests and concerns. And it was important to feel comfortable to have clear communication and open and honest conversations with each other before and throughout the pregnancy. I wanted her to feel like we had her back, and she wanted us to feel the same. And in the end, we became her biggest advocates, and she became our biggest advocate. Once our surrogacy contract was signed and our IVF cycles were completed, we had one single embryo to transfer into our surrogate, which thankfully was successful. That whole process took almost 2 years for us because we had experienced a few unsuccessful IVF cycles, which delayed the whole process. Throughout the pregnancy, I was as involved as I could be. I went to all doctor's appointments. We covered all costs associated with the pregnancy, including time off work, travel expenses, medications, extra food, maternity clothes, extra daycare costs for her children during appointments, and for labor and delivery. During the pregnancy, because I completely trusted my surrogate with the pregnancy itself, I focused more on preparing for baby versus pregnancy. So instead of reading books on pregnancy, I read books on babies, how to create good sleep habits, parenting, that kind of stuff. I did feel it was important to start the bond with our baby early on throughout the pregnancy, so we did things like recorded our voices, reading stories and singing songs, which our surrogate played for our baby by putting headphones on her belly. Our surrogate felt comfortable having us in the room during labor and delivery, and once our baby was born, he went right onto my chest for immediate skin-to-skin contact. The delivery of our son was incredibly unique and special. Our surrogate told us what she needed during the labor portion, and once it was time to push, I laid beside her so that our son could be placed on my chest right away. It was honestly truly like a magical moment, as you would expect. After delivery, we were able to stay with our son and our surrogate in one private room. Our surrogate expressed the first few ounces of breast milk for our son to take using a bottle. We then used donated breast milk for the first 3 months. And I know women who have not been pregnant can breastfeed, but this wasn't an option for me because of one of the medications I'm on. However, I know it is possible. After our baby was born, our relationship with our surrogate kind of just went back to the way things were before, and our journey as parents began. Before our due date, we did meet with the maternity social worker and their coordinator on the maternity ward to discuss labor and delivery with our surrogate. We wanted to be as thoughtful and planned as possible in order to prevent any hiccups. At the hospital where my surrogate delivered, they had an archaic policy that only the person who delivers the baby could stay in the hospital with the baby after visiting hours were over. So initially, it was expected that my husband and I would leave our newborn baby with our surrogate, which was obviously not ideal. It was also not something my surrogate wanted because she was healing and trying to rest and taking care of herself. So we were concerned about that. We ended up kind of teasing that out with the social worker and the nurse coordinator. And in the end, I was able to stay with our baby after visiting hours were done. I think because I didn't carry my son throughout a pregnancy, I was sensitive to how strong a bond I wanted to create with my son. And connecting and bonding with my son was such a huge priority for me. We did tons of skin-to-skin contact. And even though we bottle fed, I would often do skin-to-skin during feeds. My husband and I were the only people who fed our son for the first few months. And now I have no doubt that the bond we've created as a family is incredibly strong. And we have such a unique story because we have the privilege of using a surrogate. There are several advantages to using a surrogate and bottle feeding when you're trying to preserve your health. Pregnancy and breastfeeding is obviously hugely demanding on a woman's body, especially when your body is already under the extra stress CF causes. For me, using a surrogate simply allowed my body the freedom to stay as healthy as possible without the extra strain. And bottle feeding also had advantages. Because we bottle fed, my husband would often do night feeds so that I could catch up on sleep. We did use donated breast milk as much as possible because that was really important to me too. From my husband's perspective, there were definitely things he felt he missed out on, like seeing me grow our baby, but ultimately he and I both shared the same feeling that it was better to use a surrogate to increase the chance of me staying healthy. And from my surrogate's perspective, she told me that the kind of emotional connection she had with our baby was completely different than the connection she had while carrying her own children. She also recognized everything that I had to give up for going pregnancy, and she felt it was a million times easier for her to do the physical task of growing and birthing a baby compared to that of parents, moms in particular, to do the more emotional labor associated with the surrogacy process. She felt it was a much bigger ask of the parents than it was of her as our surrogate. In closing, I think surrogacy requires open and honest communication, compromise, and most of all, trust. I think you need to allow yourself to process potential feelings of loss having come to the decision to use a surrogate. You obviously have to consider costs associated with the process and what you're giving up. But I think one of the most important things is to really think about what you're gaining. Seeing the benefits of using a surrogate versus what you've had to give up frames your whole way of looking at the whole process. I also think that if you've gone through the hardships of infertility, you gain a different kind of perspective and appreciation. And I swear every day I draw on the lessons that I learned as we navigated through infertility and surrogacy. Today, even just this morning, as my 2-year-old is having a complete meltdown because his banana broke in half as he bit into it, I think about like how badly I wanted him and the lengths that we went to get him here. And it really does help me get through the tough moments as a parent. Before I wrap up, I did just want to say a big, big thank you to Dr. Taylor. Dr. Taylor was our doctor. She was fantastic. Thank you, Dr. Taylor, for speaking today. I know you're super busy. And so taking the time to prepare such an informative talk is very much appreciated. And I also just wanted to say before I finish that if anyone out there wants to chat more one-on-one with me about surrogacy, I'm very open to connecting outside of this. I had 2 women share their surrogacy stories with me as we were going through the process, and I found it so helpful talking to somebody who had been through it. So I'm very open to that. So that's my journey, and we're open to questions.
All right. Thank you, Kim, for sharing your experience. So next we have the question period. Thank you to everyone who already sent in their questions. If there's any additional questions, just please use the WebEx box to ask, and I will read them aloud. Our first question was already addressed in Dr. Taylor's, but I'm going to reread it just because it is a 2-parter. So the first question was, does CF impact ovarian reserve, and what does it mean for family planning? And then it says, i.e., is it a good idea to consider harvesting or freezing eggs earlier?
That's a very good question. And, you know, whether you have CF or not, you'll talk to a fertility doctor, and they'll almost always say it's a good idea to freeze something when you're younger. The biggest toxin to fertility in 2019 is advancing woman's age. So women come in at 35, 38, 40, and, you know, by that time, fertility is reduced because of egg quality and count. So there's not a woman that I would sit and say, oh no, wait till you're older to have children or to freeze something. So I'm very pro freezing if you can. And I think if I focus that answer into the CF scenario, I would suggest if you find yourself in your mid-late 20s and you're quite healthy and you're feeling good, if you've got the resources, because it's very expensive what we do, I recognize that. If you've got the resources, freezing something when you're younger is a great idea. Now, freezing something is the cost would be in the range of $10,000 or $12,000. It's about 2 weeks of medication. And the big thing about freezing, it's not a guarantee of a baby in the future, but it does give you a pretty good shot and certainly a higher chance than you would if you waited 5 years and tried to get pregnant. So younger eggs are better. If you can freeze, it's a good idea. Now, how do you get to that point of even contemplating freezing? I mean, I think what you probably want to do for most people who have not yet started their children is go get some basic fertility testing, like go see your family doctor, even a walk-in clinic. If they're decent physicians, they themselves can send you for basic blood work to see what your egg count is. That is an FSH and estrogen level, which is covered in every province in Canada, is covered by the health plan, or an AMH level, which is not covered in most provinces, and it's about $100 here in BC. But that will give you a sense of your ovarian reserve or your egg count. And knowing that's really powerful, because if you're 28 and you know you have an amazing egg count and you're planning to have kids when you're 32, don't freeze anything. Just go get pregnant at 32. But if you're 28 and you find out that you have a low egg count, particularly if you're planning on waiting a while before you have kids, then freezing really makes a lot of sense. So that basic fertility test, which, like I say, even the basic one is covered by MSP. Any family doctor can order it, or if you're getting into trouble, you just contact me and I'll order it for you, or you can come and see a fertility clinic in your area. Really simple way to just find out where you are on that spectrum of egg count, which really reflects your overall fertility. Now, I wanted to just pause too and thank Kim for including me in this, and actually telling her story is very, very valuable for me to hear her story, because I don't often hear the patient's perspective. I see them at these moments of joy and these moments of crises, and I don't often get to see the big picture. So that was really, really wonderful to hear that part of Kim's journey. So thank you to Kim for all that.
All right, so the next question is, are there any risks with using sperm or egg donors or a surrogate?
So most sperm and egg donors that we use in Canada are anonymous. So you never meet them, you don't know them. Typically they donated at a clinic in the US, and their eggs or sperm are shipped here. So legally there are no issues. Sometimes there can be psychological issues, but there legally are no issues. And in terms of medical risk, it's really low risk to use an egg donor surrogate, because if you use an egg donor, you yourself are not going through the IVF process. So there's really like no kind of major hardship on your body, because the hardship comes from the people who we're extracting eggs from. So it's really I would say there's no medical risk to egg or sperm, using an egg donor or a sperm donor.
All right, and the next one is how to decide to go through surrogacy versus pregnancy, and what are some factors to consider when deciding to go through surrogacy or pregnancy?
So that decision is often, I think Kim articulated really well what her decision-making process, and I bet there's a lot of people in that following that same route of considering your health. I think women know their health the best. So they know kind of how they think they can manage a pregnancy physically, and they also have guidance from their CF physicians as well. But if you're having frequent exacerbations, you're being hospitalized, pregnancy is not a good idea, and you should really tip yourself towards surrogacy. Now, there's also, sadly, there's a financial consideration here too. So many people simply cannot afford surrogacy because it's just extraordinarily expensive. So that can also tip people towards taking maybe more pregnancy risk for financial reasons. But ultimately, the decision of whether you carry yourself or you use a surrogate is a personal one, informed by what your CF doctors are saying. Like some of these CF reports will say, I think pregnancy is contraindicated. This woman would be extremely high risk. I estimated her mortality at 30%. Those kind of reports are really clear you should do surrogacy. And then other reports are like, well, she would be at higher risk, but she'd like to pursue this. And so it's really personal. I'm giving a wishy-washy answer to that question, but it is kind of personal, but informed by really the CF side, and it's not really me making those decisions. So I would probably put the brakes. Well, I would put the brakes on it if I saw that the CF doctors were not comfortable.
All right, and the final question of the pre-submitted questions: is there any tips for how to settle on the decision to either use a sperm or an egg donor or a surrogate? Yeah,
I think surrogacy is a medical. I think it's informed by your health. Egg donation and sperm donation is a really interesting one. And every case is so unique, right? Like, so someone will have cystic fibrosis and they'll have a terrible family history of mental illness, or they'll have a terrible family history of some other disorder that they're concerned about passing on. And those people will tend to try to opt for egg donation or sperm donation, depending on the situation. But most people come to the table wanting to use their own eggs or sperm. So usually we try with their own eggs or sperm first, and then egg donation and sperm donation happen when we're not finding success with their own sperm or eggs. That makes sense.
All right, so just to open the floor, are there any additional questions for Dr. Taylor or Kim, or would Kim like to add anything extra? I feel like I didn't quite draw on you for this question period. I apologize.
That's okay. The only thing that I was going to add to the first question about trying to decide whether you should freeze eggs or not, I think if I was told, because we had egg quality issues and egg quantity issues, and so that was one of the reasons why we had to do so many cycles of IVF. And so if I was told that that was something that should be pursued, like in my 20s, I think I really would have thought more carefully about that. I think for me, I just really took for granted the fact that in my 20s I was young and we didn't have any fertility issues in our family, so like I really didn't think it would be a problem. And then once we started trying, it was kind of surprising to me how quickly time was going by. It was like all of a sudden, it was 3 months later, just waiting to see specialists, waiting to see what my health was doing. That was such a long process. We kept thinking that, I'll probably be stable for 6 months. Let's just wait. But that time just added up. And so that would be one thing that I wanted to add, just as a little piece of advice to people if you're thinking about having kids down the road. As Dr. Taylor suggested, get everything checked out and tested just so you have more information and then can make a more kind of informed decision about family planning.
All right, so there are no additional questions at the moment. So I'd like to end by saying thank you to Dr. Taylor and Kim Wood for taking the time to join us to speak on fertility and family planning for people living with cystic fibrosis. Thank you to all of you for tuning in today. Our next webinar on cystic fibrosis and pregnancy will be in November, and we invite you to keep an eye on our Facebook page for more information on the series. All questions can be directed to advocacy@cysticfibrosis.ca. This webinar was recorded and will be made available for future viewings. Thank you to everyone for joining us.